Okay, let's spend some time talking about contrast agents. So, in general, for the contrast agents that we use in radiography, we are looking for substances that have a different atomic number than the tissues and organs and materials within the body, right? Generally, we're looking for things that have a higher atomic number, and we're going to call those positive contrast agents because they have a higher atomic number, and so they show up very white on the image. Occasionally, we will use some things that we will call negative contrast agents because they have a lower atomic number or lower density than the tissue, and so they will show up dark on the image. Okay? These I've listed here are the 5 major types of contrast that we play with as radiographers and as CT technologists. So I am lumping CT in with this discussion. The first, LOCM, stands for low osmolality contrast media. We'll unpack that term some more. But again, it stands for low osmolality contrast media. Generally, when technologists are talking about it, they call it IV contrast. But it differentiates it from high osmolality contrast media, which would be HOCM, which we used in the past. So prior to the year 1980-something, we used high osmolality contrast medias, and people tended to have reactions to that more frequently than the contrast media that we have now. Okay? So we will look at low osmolality contrast media, which is a positive contrast agent, in some more detail. The number 2 most common contrast media that we play with is barium sulfate. Typically it's in some kind of flavored form, or we're mixing it up into different consistencies. Barium is an actual element on the periodic table, and its contrast properties were discovered by Thomas Edison. So we use it primarily for the digestive system, right? And we'll talk about different types of barium sulfate, but just know that for the time being, it is a positive contrast agent. The next positive contrast agent that we will work with is water-soluble contrast agents. These are still iodinated contrast agents, meaning they have iodine in them, but they can be mixed with water and then used as an oral or rectal contrast or intercavitary contrast. The most common one is gastrographin. We will mix it with orange or apple juice and let the patients drink that. So it is still a positive contrast agent, but it would be our go-to in the case of a bowel perforation. So if the patient has a bowel perforation, we do not want to give them barium. We would then mix up some water-soluble contrast agent. That is not to be confused with water itself. Water can be used as a contrast agent. So it's number 4 on my list of most popular contrast agents is water. It has close to a negative value. So it is much less dense than bone, in other words. So it is closer to gray in color. It is not as commonly used in X-ray as a contrast media, but we still use it some in CT. The last ones are air or CO2, so that would be carbon dioxide. We may use some type of carbon dioxide insulfation, or a process of adding carbon dioxide to particularly the gastrointestinal tract as part of a double contrast GI study. We may also just use room air, right? The most common form, even though I've got air at the bottom of the list, it is actually the most common form of contrast that we use, and then we use it in this way. Take 2 deep breaths in and hold it. So every chest x-ray you ever take, you are using air as a contrast agent in that examination. You're using it as a negative contrast agent. Okay, osmolality refers to the number of particles in solution per unit liquid as compared with blood. So when we talk about osmolality in medical radiography, we're thinking about it as compared to blood, because it controls the amount of particles in solution in the blood is part of how the body controls where the blood goes and where it doesn't go, right? Or where different things go. So we've heard about, for example, the brain-blood barrier, right? Where there's an osmolality difference between the blood and the brain, and so it's used as a barrier to keep certain things out of the brain, right? So that's part of how osmolality is used by the body. Now, IV contrast media has a certain amount of particles in solution. So we've placed iodine, we've bound it to some kind of carbon to where it looks like a carbon-type organic thing. So the body thinks there's just this weird organic thing that's floating around now in the blood. So it's going to respond in kind, because we've injected about the amount of a can of Coca-Cola of this stuff directly into your vein, right? So if we add a can of Coca-Cola directly to your veins, we've increased the amount of particles per solution throughout the entire blood system. The body will respond. Largely what it will do is it'll do things like drop the blood pressure, right? Because you've just added more stuff. So we need to increase like the size of veins and things to account for this added liquid, right? So all of that is part of this osmolar type aspect of IV contrast media. So when we talk about low osmolality contrast media, those are contrast media that are close to blood, versus high osmolality contrast media are those things which are much higher than blood in terms of the number of particles in solution. Now, you do not need to memorize the fact that blood has 290-something molecules per kilogram or whatever. That's just giving us a ballpark of what in general we're talking about. So let's talk about HOCM, or high osmolality contrast media, versus LOCM, or low osmolality contrast media, because we've mentioned that there's already some myths that come up about IV contrast. One of the myths, or a lot of myths, come out of this distinction. So high osmolality contrast media could have as much as 7 times the osmolality of blood, hence it's called high osmolality, versus low osmolality is normally roughly twice the osmolality of blood. Almost every, well, I'll tell you this, every contrast, IV contrast I've ever used at any facility that I've worked at in the 15 years that I worked as a CT scan technologist was LOCM, right? But, like I said, back in the day, we did use HOCM. And the higher osmolality, if you can imagine, that increased amount of particles in solution caused a more increased response from the body. So if I've told you that the body has to do things like increase the size of the veins to accommodate the amount of fluid, and that as a result decreases blood pressure, it might change its heart rate slightly to accommodate the stuff that's been injected into the venous system. All of that could go awry at some point. So the body might hyper-respond to this increased osmolality. And that then would be a problem, right? So we have things like what we talk about anaphylaxis or anaphylactic shock, where the person's blood pressure bottoms, right? This would be a dysregulated response to the introduction of contrast media. Why that response is triggered, I'll be honest with you, is a mystery right now. No one knows. But we're trying to understand this stuff as best as we can so that we can avoid whatever parts of it we can avoid, right? But a true contrast media reaction is not an allergic reaction. It is not an allergic reaction. It's a reaction to something about the contrast media that we still don't quite know. We will call it anaphylactoid or allergy-like, because it behaves kind of like an allergic reaction, but it is not a true allergic reaction. The biggest correlation we have found between whether or not a person is going to have a contrast reaction is whether we use high osmolality contrast media or whether we use low osmolality contrast media. So again, every facility I've worked with has recognized the potential costs and patient care problems, and they've all opted to use LOCM. There is still some HOCM out there according to the CT textbook that I use, but I seriously doubt that there's very many facilities choosing that just because of the added risks. Viscosity, like we said, is the thickness or friction of the fluid, so you can think about it as being like friction. Viscosity is like friction. And one of the things that we do is warm the contrast media to reduce viscosity. So warming up the contrast media is going to make it have less friction. And one way to think about that would be like if no one, I don't think, stores maple syrup in their refrigerator, right? Because if you did that, you would basically, are there people that do this? There are people that do this.
My parents do it.
Okay.
I said something to them about they're the only people that do it.
They may be the only people that do that, because if you do that, you're basically making rock candy, right? Because you are doing what? You are increasing the viscosity of the maple syrup, right? Most restaurants that you go to maybe have their maple syrup in a warmer or by the oven so that it's warm and it pours easily. Same thing happens with contrast media. So very often, in CT especially, we have the contrast media warmed up or in a warmer that allows us to reduce viscosity. Ionic. So one of the ways that technologists may talk about IV contrast media is they'll say it's non-ionic contrast media. Do not be confused. That does not mean it does not have iodine in it. It does have iodine in it. Iodine is the primary IV contrast that we use. All the different brands of contrast media that are out there use iodine in some way, shape, or form, with maybe one or two exceptions. But they do things with the iodine. They pair it with other stuff that fools the body to think it's just an organic compound, like it's like a useless protein floating around, right? I've had technologists say, though, non-ionic contrast, we're not using iodine, so don't worry about it, right? That's not what it's referring to. When we say non-ionic, we mean that the molecules do not dissociate into ions in solution. So in the past, we used ionic contrast agents, and the molecules that we had made, the little organic molecules that we had made, if they floated around in the blood long enough, they dissociated, and the carbon parts and the iodine parts floated apart. And so they had a tendency to dissociate into ions. These can be either LOCM or HOCM. So a low osmolality contrast agent can still be an ionic contrast agent. But again, almost everything that we use is a non-ionic, low osmolality contrast media. Non-ionic, low osmolality is what we like. But here's some examples of stuff that are ionic contrast agents. Hexabricks, I think, has been taken off the market, but I think it was one of the very first contrast agents that was used for IV injections and things. That was developed by the Mallinckrodt Institute in St. Louis. Conray, renographin is maybe still used by urologists and things like that. So non-ionic is what we tend to use. These are molecules that do not dissociate in solution. They can be LOCM or HOCM. But here's some of the most common ones. Ultravis, Omnipaque, Isoview, and Visipaque. This is what they use in most of the Baptist facilities, Omnipaque. This is what I have used almost everywhere that I've ever worked, is Isoview. They're very, very similar, just made by different companies. Clearance. When we talk about clearance, we mean the half-life or how long the IV contrast hangs around in the body. right? And so we're talking about clearance in terms of renal clearance, which is the way that, for example, the lab thinks about things. So when we're using contrast, we're thinking a little bit more like nurses or more like lab techs about things, right? And when a nurse talks about clearance, they're talking about how much fluids are passing through the kidneys and being excreted out of the body, right? So half-life, in this respect, means the amount of time that it takes for half the dose of the IV contrast to be eliminated from the system. For patients with normal renal function, that half-life is typically 2 hours. So within 2 hours, half or more than half of the IV contrast is gone. They've gotten rid of it. In fact, a lot of it they get rid of the very first time that they go pee, right? Because we actually see the contrast. A lot of the tests that we do, we actually see the contrast being collected by the kidneys and sent down to the ureters to the bladder, and that's how we're imaging that stuff. So if you can picture this, that's how it's actually being cleared from the system. Dosage. Now this talks about CT protocols, and so I am asking us to put on our CT hats just a little bit and start thinking in this direction. Different CT protocols will use different doses of IV contrast. The same is also true for different protocols that we use in the radiography department. The dose we are going to relate to injection rate, the volume, and the iodine concentration, right? So just know for right now that in general, we are going to keep doses as low as reasonably achievable with IV contrast, the same as we do with radiation, right? Because what we do know is that the deaths related to contrast media injections, if you're worried like, oh my goodness, are all these patients going to die on me? No, most all of them have been related to high osmolality contrast media, which I said we do not use, and this dose is insane. 250 to 300 milliliters. In the past, in our example, we said we're giving them one Coca-Cola, right, or maybe one of those baby Coca-Colas. This would be like having them drink the 2-liter Coca-Cola, right? That's a lot of Coca-Cola. So that would be a real problem just related to the dose. Dose limits. We'll come back to this. This is not anything you need to necessarily remember right now. One of the things that's of very much interest to me is why don't we use some kind of dose limitation process. Right now, for most IV exams, we have a kind of one-size-fits-all way of doing things, and we don't recognize that, for example, a 400-pound patient does not need the same amount of contrast as a 90-pound patient. There's a huge difference in the amount of contrast we could give those patients, right? But what happens in most CT departments and most X-ray departments is they both get the same dosage of contrast. That's not necessary. We could base doses more accurately on weight, which is what we do typically with pediatric dose. We get their weight in kilogram, and we say 2 milliliters of contrast for every kilogram of their weight. So we do it with peds. I don't know why we're not doing it with adult populations. Safety. So I know that what I've been stressing right now is that contrast media has some risks related to it, and that's the way that I would talk about it with the patient. There are risks related to IV contrast use. But it is widely used, and it is largely safe. So when I talk to my patients about the IV contrast, I stress with them, hey, I'm going to get a history from you about the things that you're allergic to and some other health conditions. I'm just trying to be as safe as possible. This contrast that we're using is going to help us a lot to see what we need to see. But there are risks related to its use. And so we know exactly what those numbers are. The risk is a little bit less than 0.001%. 0.001%. That's actually a really helpful number to know. Like, if I'm trying to quantify risk with someone, and they're like, man, you're asking me a lot of questions about this stuff, it must be pretty dangerous. The two ways that I talk to them about the risk is I could say, you know, yeah, there are risks of people having problems with this stuff. The risk factor is about 0.001%, right? That's kind of to the nerdy folks. If it's a less nerdy person, I might say, yeah, there are risks related to IV contrast reactions. There also are risks related to drinking Coca-Cola. They're about the same. So if people have problems with Coca-Cola, Coca-Cola Foundation has to report that, right? Same thing here. Only we're not, Coca-Cola Foundation is not doing the stuff that we're doing in hospitals. Contraindications, reasons why we would not want to give IV contrast or possible problems that could come from IV contrast usage. The number one for me is contrast-induced nephropathy. This is not necessarily an allergic reaction or anything like that. It's kidney damage related to contrast and sulfation. So we give the patient IV contrast, and they don't listen to our warnings about not drinking caffeine. They go home and drink a six-pack of Coca-Cola, and now they have caused irreparable damage to their kidneys. And they're in a state of shock, like prolonged shock, referred to as SIN or contrast-induced nephropathy. There are contraindications related to hyperthyroidism. If the patient has a history of hyperthyroidism, we could potentially cause a thyroid storm. Nuclear medicine thyroid studies actually damage the thyroid or change thyroid function. So if they have had a nuclear medicine study recently or are about to have a nuclear medicine study, we would want to question the use of IV contrast. There are risks for pulmonary hypertension, bronchial asthma, and congestive heart failure because largely we're introducing quite a bit of a solution through the veins, and the hypertension could actually cause an even increased amount of blood pressure since we're doing this injection pretty quickly. Same with congestive heart failure. There are a risk of causing a seizure if a person already has a seizure disorder. The studies that I've seen most recently say that giving the patient Valium prior to IV contrast injection can help alleviate, if not completely stop, the potential seizures. In fact, I would love it if we just gave Valium to everyone before we give them IV contrast. That would be great. There are contraindications if the patient's severely dehydrated. Again, we would not want to give them something that's very sticky and like hot Coca-Cola syrup if they're already dehydrated. The body would have that much more difficulty getting rid of it. And then finally, extravasation. Are we familiar with that term? Extravasation means it went outside the vein. It's extra vein. It is outside the vein. It exited the vein. This would be a problem if we're injecting something about the size of a can of Coca-Cola into a vein and the vein blows. I've just injected 12 ounces of junk beneath your skin, and it doesn't need to be there. It was supposed to be in your venous system where it could be distributed through your whole body, not stuck right here in front of your elbow where it could eventually damage that joint. So that is a risk, and that's why we're going to talk about IV placement and making sure that we're getting good IVs prior to any kind of, especially mechanical injection. Adverse reactions. So there are different reaction types, and we grade them in different ways. Just know that there are different reaction types for right now. We'll look at what happens in acute adverse events, how to assess that, what responses are needed, and how we can prevent that. So here's some reaction types. This is what we need to know right now. There is subjective reactions to contrast media, and I don't want to de-emphasize these, but these are largely related to where the patient's at just as an individual. So the things like we talked about, the feelings of heat, the nausea, the flush feeling, the metallic taste, those are all subjective. Some people taste that taste, some people don't. Some people feel like they wet their pants, some people don't. Everyone's a little bit different. The most extreme subjective reaction would be the vasovagal reaction, where the person literally passes out or starts to act like they're having an allergic reaction, even though it's just their anxiety. These can be pretty extreme. I had one patient, for example, it was a younger man who had non-Hodgkin's lymphoma. I scanned him several times as a CT tech at a cancer place, and because he had these like 2-month follow-ups. He was like the kind of guy, you know, the skinny white guy that's always wearing like death metal t-shirts. He was one of those guys. So he looked like pretty metal, like he could handle this thing. Every single time I gave him the IV contrast, he projectile vomited. Like it was like this perfect fire hose stream of vomit, like all over the CT scanner. And it's like, dude, I thought you were more metal. Like, why are we having this problem every single time for the last 4 months, right? He was having a severe subjective reaction to something about the contrast media. Eventually we gave him Valium, tried that, didn't help. It got to the point where I would just do the injection, have him puke in a barrel, and then we would do the CT scan. It just happened every single time. So lots of fun. So they can be pretty extreme. Chemotoxic, these would be responses or reactions to the actual physiochemical properties of this junk. And the good example of that is contrast-induced nephropathy. The stuff hung around in our system, and now its chemistry is hurting the kidneys, right? And then finally, what we would call idiosyncratic or allergy-like or anaphylactoid. Most of these occur within 5 minutes of IV contrast injection. And the incidence is about 4 to 7% with LOCM. What does that mean? It means about once every blue moon. If you're at a regular facility, about once every blue moon, someone's going to have one of these allergy-like type reactions. So let's talk about the acute adverse events, okay? The majority of these idiosyncratic reactions to contrast media are mild, meaning the person will feel like their throat is closing up, but it won't close up completely, right? The person's going to have hives in the area of the injection, but not all over their entire body. It's a fairly mild thing. But we're also going to include in that mild response things like heart palpitations. That's kind of scary if you ask me, and that's considered mild, right? The risk factors, the big risk factors that we think about, like I said, is previous contrast media reaction. That's the #1 risk factor for having another idiosyncratic or anaphylactoid type response. Asthma is a risk factor. Allergies to everything, like we said, food, drugs, dogs, and then the different types of drugs that they're actually taking. So I'm differentiating, when I say drugs here, I just don't mean drug allergies. I mean if the patient's on this laundry list of drugs, particularly drugs for things like diabetes and some cancer drugs and a lot of other drugs, those could actually put them at a risk for having a contrast reaction. Here's how we're going to assess that stuff. We're going to use the terms mild, moderate, and severe. And here are some of the signs that we are going to use. Hives is one of the most common ones, as is diffuse erythema. So it's one of the reasons we want to talk to the patient the whole time we're doing a contrast injection. How are you feeling? I need you to talk to me. Because if they can't talk, it means that they're having laryngeal edema, right? But hives, I'm going to be watching the patient, looking for redness or hives around the area of the injection. If they have a bronchospasm or laryngeal edema, a lot of times the first thing I've seen is the person sneezes. If they sneeze when I start a contrast injection, chances are they're headed to here, right? I don't know why that is. It's just a funny thing that happens. You start an IV injection and they sneeze. It's just a funny thing that happens. Hypotensions, now we're starting to move more towards the moderate thing. If their blood pressure is dropping, you've got a problem on your hands, right? As would be unresponsiveness, pulmonary edema, we're moving from moderate to severe, right? Seizures and convulsions sounds pretty bad to me, right? Hypoglycemia, anxiety rebound. So if the person comes back around, if we administer epinephrine or whatever, we pull them back around, we need to continue to watch them, because even afterwards they're going to continue to be kind of anxious and may have some difficulty with, we want to keep them in the department and monitor them for a while. So here's some responses that we use. We want to make sure we preserve IV access. Do not take out the IV. That is a really crappy response. In fact, that'd be a great exam question. Like, in the event of a contrast reaction, the technologist should what? Remove the IV? No, they do not need to remove the IV. The stuff that we can do is monitor their vitals, particularly with a pulse oximeter and blood pressure, and then we need to alert the physician or the nurse. It's going to be their job to take over and start doing this stuff. We do not need to be doing this. Even stuff like having them on O2, that is a drug, and it has to be, there needs to be a script written for that by the physician, right? So, person has a contrast reaction on my watch. Very first thing I'm going to do is alert the physician if it's severe enough and start monitoring their vitals and taking notes on things like their pulse ox. The physician's going to be handling this stuff. I could be documenting. And then if it gets severe enough, we might need to call a code blue. So, prevention. Number one way to prevent it, use low osmolality contrast media. We can pre-medicate. You don't necessarily need to memorize this pre-medication protocol. This is just one that's commonly used by a lot of facilities. It basically, these are things like prednisone and Benadryl that are antihistamines. They're going to reduce the likelihood of a person having a histamine response, but we've said it's not really an allergic reaction. So why we do this is debatable right now. In fact, I've seen recent debates about this is completely useless and just costly. And then we're going to document. If they've had a reaction, or if they have one on my watch, I'm going to make sure to tell them. Make sure you tell the tech. If you get another CT scan, you had a reaction today. It was a minor reaction, but you had a reaction to the contrast media that we used. And document. Okay, switching gears a little bit. Now I'm moving out of the world of LOCM and IV contrast into the world of barium. So I'm also moving out of the world of the venous system and the cardiovascular system and into the world of the digestive tract. Right? We are still in the world of positive contrast agent. So barium's our number 2 favorite positive contrast agent. The anaphylactoid type reactions to barium are very, very, very uncommon. The severe reactions are 1 in 2.5 million examinations. In other words, I've never seen a person have a reaction to barium that I know of. I've seen many IV contrast reactions. I've never seen a reaction to barium. Can they happen? Yes. They're incredibly rare. Generally, we use it as some kind of prep, or we use it as a rectal contrast. The prep might be anywhere from 1 to 4 hours, depending on the examination. So, for example, a prep from CT would be to have the patient drink a bunch of barium and then scan them after 2 hours. For us with a small bowel follow-through, we'll do an initial image, have them drink some barium, walk around, and then do images every 10 to 30 minutes or whatever the protocol is at that facility. Okay? I think it's generally 10 minutes. Contraindications, we've said obstruction, because the barium can actually cause obstruction, perforation, a tracheoesophageal fistula, and if, in other words, it could get from the esophagus to the trachea, that would be really bad news. Really bad news. Generally, if a person's got that going on, though, they got a lot of other stuff going on. Like, they've got stuff and wires coming out of every part of their body. And so it would be well documented. But the concern with that would be that the barium would enter into their lungs and cause actual increased pneumonia. That would be like calcified pneumonia, because that barium's like heavy, inert stuff. Pyloric stenosis, for the same reason, we would want to be careful with the stomach, right? We do not want to cause this stuff to leave the stomach in any way other than into the small bowel. And then a known hypersensitivity. If the person has actually had an allergy to barium, we would not want to give it to them. Adverse reactions. Number 1 is probably diarrhea. And you always tell the patient, if you've given them barium, it goes in white and it's going to come out white, because they will freak out the first time they go to the bathroom and they get a ghost poop, right? but it causes diarrhea for most people. Abdominal cramping, impaction is a rare possible thing. Barium appendicitis has been documented, where the person actually got appendicitis from the barium. It got stuck in the appendix. Intestinal perforation, that would be with a person who's already got some intestinal problems, and then peritonitis, right? So if it gets outside of the bowel, it can get into the peritoneum and cause an infection within the peritoneum, right? Which would be a messy infection because it's barium plus bugs, which is really gross if you think about it. Water-soluble contrast. So I'm switching gears yet again, and I'm still in the world of the digestive system, but I'm not using barium. So if the patient has any of those laundry lists of contraindications, I'm going to think, maybe I shouldn't be using barium. Maybe I should be using something water-soluble. The big example that I can think of is gastrografin. Has anyone here ever tasted gastrografin? It reminds me of one time I had this really cheap Korean whiskey. It tastes like cheap Korean whiskey. It's really bad. No slight against Korean whiskey distillers, but it ain't bourbon. So this is... Gastrografin or Korean whiskey? Gastrografin is spelled Gastrografin. Gastrografin. It has 2% to 5% solution of LOCM. So we're going to mix it, is what this is saying. We're going to add, just like with any recipe, it'd be like 1 part of gastrografin to like 2 parts or 3 parts of apple juice, right? We're going to have to mix it up. And we're going to have more of whatever we're mixing it in than the gastrografin. And every facility has their own little mixing protocols. It can be rapidly absorbed, and so we want to avoid patients who are dehydrated. If we're going to go this route, we want to make sure that they've either had some IV fluids or that they're perfectly hydrated, because if what happens is the gastrografin is introduced to the digestive system, it gets to the large bowel and it's not causing distension of the bowel just sucks all the water out of it because the patient's dehydrated, then we just defeated our purpose, right? So we want to make sure the patient's very hydrated so that their body is not going to fight against us trying to get this study. There's a lot of reduced risks, especially when we're using it for the kids. So a lot of times if we're talking about babies, we aren't going anywhere near barium for babies. We want to think about gastrografin immediately if we're working at a peds hospital. A lot of times with the pediatric hospitals, they don't even have barium in stock. They just automatically use the water-soluble stuff. Water. We can use this as a negative contrast agent primarily in CT. The problem with it is it's difficult to fully distend the bowel. It is more or less a negative contrast agent. It is closer to something like air. It's going to show up as a dark gray. So it is not useful for X-ray, just in CT. At this point, you don't necessarily need to know a lot about water. Okay. Air and CO2. We will use these as negative contrast agents for imaging of the GI tract. We may give the patient some kind of antispasmodic drug like glucagon hydrochloride to further improve bowel distension, right? So they may offer the patient glucagon prior to doing like a dual contrast barium enema, where we're insulfating both barium and air into the digestive tract. In addition to that, these antispasmodics can help the patient with the discomfort related to you putting a massive fart in their large intestine, right? Because that's what we're doing anytime we're adding air to their bowels. And if you can imagine that weird, terrible feeling that you get right before passing gas, imagine that times 10,000, and you have some kind of notion of what it is we're causing these patients to feel. It's not very pleasant. That's one of the reasons why we started using CO2 as opposed to room air, is it can actually reduce the amount of spasms that are caused within the large intestine. So CO2 is a little bit more patient-friendly than room air. All right, that's it. We got through everything without having another thingamajigger. So I think I actually forgot to set the timer. So yeah. All right, but it does my teacher's heart good to see y'all taking notes. So let's take 5 minutes, and we will start back up at 3:15 on this clock. 3:15.
Do you have to read the packet for this information? It's not in the book.
What information?
Like, if it's in the book.
What book?
Our textbook.
There's information in the textbook about it?
That's my bestie.
I don't think there's any information in the textbook about it.
Okay. So I need to read the packet.
Yeah, I would read the packet.
You're so helpful.
I was confused by the question. Like,
That's how I feel on your test.
why would? But the thing is, why would I put together a packet if it's in the book? That's a lot of extra work for me.
I wasn't here last week, so I didn't know about
Oh, that's right. Okay. Read the packet.
Yeah, got that now.